to the first meeting of 2021. We're going to start out with our roll call and introduction. And so with that, if we can bring up the P&T committee list, let's go right down the list. You can briefly introduce yourself, give a little background. That'll help three new committee members that we have joining us today.
Hi, I'm Mark Helm. I am a pediatrician at Child Health Associates in Salem, and have been on the P&T committee now for, I guess one term. And that's it. That's about it.
Welcome. Russ.
Hey, my name is Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health. And, I've also been on the P&T committee now, finishing my first term.
Fantastic. Thank you, Russ. Jim wasn't able to join us today, so we'll go on to Kathy. Kathy, not able to hear you. You might still be on mute.
Pharmacy manager at Salud Medical Center. We're part of Yakima Valley Pharmacist Clinic. I've been on the committee since inception, and I'm not sure when we started, but it's been a while.
Yeah, 2011. Thank you for your service. You bet. Pat DiMartino.
Hi, everybody. I'm Pat DiMartino. I'm a pediatrician and a PET-MONC fellow at OHSU, and I've been on the committee for just 1 year.
Super. And Kat, whose name that may be familiar to, is replaced for the finishing the term for Dave Pass, but new to the P&T committee. Kat?
So hello, I'm Kat Livingston. I'm a family physician and preventive medicine physician. And though I'm new to P&T, I actually served for 10 years with the Health Evidence Review Commission, so I have a deep familiarity with prioritized lists and the work of P&T. So I'm excited to be on this side of it. And I'm currently the medical director of Health Share of Oregon. So also bringing the CCO and physician perspective.
Great, Kat. Welcome. Stacey.
Hi, everybody. I'm Stacey Ramirez. I am faculty at OSU College of Pharmacy, and then I'm also the director of pharmacy and the clinical pharmacist for the community health centers of Benton and Lynn County. I think I've been on the P&T committee maybe 7 years now, 7 or 8, somewhere around there.
Well, we appreciate it. Thank you. Tim Langford is also a new committee member and is filling one of the 4 pharmacist roles. Tim?
Yes, I'm Tim Langford. I'm the pharmacy director with the Klamath Tribes in Chilton, Oregon. I'm also a public health officer and have been familiar with P&T for my whole career.
Welcome, Tim. Thank you. Karen Michelson.
Hello, this is Karen Michelson. I'm the pharmacy director for the Coquille Indian Tribe in Coos Bay, Oregon.
Welcome, Karen. Robin is a new committee member as well. She's filling one of the 2 public or non-pharmacist non-physician roles. So, Robin?
Yeah, I'm really pleased to be here. I'm Robin Moody. I'm currently executive director of the Oregon Health Forum, which provides public education around health policy and healthcare topics. And formerly worked in quality improvement and health policy, so really pleased to be on the committee. Thanks for the opportunity.
You bet. Happy to have you join us. And Bill.
I'm Bill Origer, family medicine. I've been doing this work for 12 or 13 years. I can't remember how long. I'm currently on the family medicine faculty at the Samaritan Corvallis Family Medicine Residency.
Fantastic. Welcome, Bill. Bill and Karen have been reappointed for another 3-year term, so appreciate your willingness to be considered to keep doing this important work. Thank you. So as this is the first meeting of the year, we need to elect a chair and vice chair. So I want to throw it out to the committee. They can help whoever the chair is and vice chair help me run the meeting. So anybody want to throw their hat in the ring for consideration?
I'm actually going to throw my hat in the ring this year. It feels like it's time.
All right. Thank you, Stacey.
You can have my hat, too.
wish to be considered, or if not, we can't end in a leg wrestle or do anything else to see who should be the chair or the vice chair. We can flip a coin, or if one of you wishes to take a lead and the other to be the vice chair and help support, or if you want to state your case. Yeah, please. Stacey, I appreciate your comment. You've been doing this almost since the inception as well. I appreciate your willingness and interest in chairing for the year.
You know,
Bill, you've done this work.
I'd be happy to be vice chair and help Stacey do this job.
That would be awesome. And I was going to say, I'm fine with either role. Sorry, my dogs are flipping out and fighting in the background, so got a bit distracted there for a second. But that would be great. Yeah, either way would be fine with me. I would appreciate that.
Move that we elect Stacey chair by acclamation.
So we have a move to elect Stacey as the chair and Bill as the vice chair, vice chair for the year. Do we have a second?
Second that.
Fantastic. All in favor? Aye.
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 Anybody opposed to proceeding with that? Fantastic. Stacey, Bill, thank you very much. Briefly, conflict of interest declaration. All of the P&T committee members and staff have filled out conflict of interest declarations. They keep those on file with the Oregon Health Authority with the expectation that if should their conflicts arise, that they bring those and update that form with the OHA. Or if any subjects come up for which you should recuse yourself, you make that known to the committee so that you're not taking action on any of items that you're making recommendations to the Oregon Health Authority. But it's very important. Additionally, anybody that's wishing to provide public comment is also required to fill out our conflict of interest declaration form. So people that will be speaking today, I think generally are from industry, so you understand that they're speaking on behalf of the company. Sometimes we have public members or advocacy, and I'll call that to your attention if they have any conflict. But just wanted to reiterate how important that is to the Oregon Health Authority for transparency when you're making these important recommendations. So one of the first items is the approval of the agenda and minutes. We don't have any expectation to change the current agenda that we have in front of you. Sometimes we move topics around. We don't plan to do that today. I did send out the minutes from the last meeting of 2020 so that the committee, at least those that were on the committee last year, had a chance to look. So for those following along with the packet that's posted on our website, again, where you found the link to join this meeting, the packet has been posted along with some written comments. And if you're following along on that packet, we're on page 4. So again, does anybody have any edits to make or recommend to the minutes? And if not, we need a motion to approve.
I move that we approve the minutes.
Okay, all in favor?
Aye.
Any opposed?
Did the newbies need to abstain since we weren't here?
Good point.
That's my question.
Yeah, we don't need your vote just because you didn't really see what they were. You could have questions on those, but no need to vote on that. So with that, we have the department update, and we'll turn it over to, I don't think Trevor's going to be with us, so you'll probably touch on that, but turn it over to Dee Weston. Oh, excuse me. Thank you for bringing up the screen. We haven't introduced the staff members as well. Kind of skimmed right over that. Let's go down the list and start with you, Jennifer.
Yeah, hi, Jennifer Bowen, Executive Support Specialist with Oregon Health Authority.
I see you're unmuted, but I can't hear you, Jennifer.
Jennifer Bowen, Executive Support Specialist, Oregon Health Authority.
Now you're muted again.
Jennifer Bowen,
There you go.
Executive Support Specialist for the Oregon Health Authority.
Great. Thank you, Jennifer. Again, my name is Roger Citron. I am the Program Manager for the Drug Use Research and Management Program. We are the contractors providing pharmacist clinical support to the OHA and help administer the P&T committee meeting. Trevor isn't here, so we'll turn it over to Dave.
Hi, I'm Dave Ankian. I'm clinical pharmacist with the OSU Durham Group.
Senator Fletcher, I know you're doing many, many things. You must unmute.
co-coordinators for the derm group.
Andrew Gibler was a previous clinical coordinator with our team. He still works with us part-time and does some of our reviews. He is not on the agenda today, so won't be joining us. Dean?
Dean Haxby, Director of the Derm Program with the College of Pharmacy.
Welcome. Megan as well was a previous clinical coordinator. She still works with us part-time, does some reviews, particularly in subject matter expert for a couple areas, but isn't with us today. Turn over to Rich.
I am Rich Holsapple. I'm Pharmacy Manager with Gainwell Technologies. We're the Pharmacy Benefit Administrator for the state of Oregon.
Great, Rich. Deanne is also on our team, one of our clinical pharmacists. She won't be joining us today, so we'll turn over to you, Kathy.
Sure. I'm Kathy Santana, and I'm a clinical pharmacist with OSU Derm Group as well.
Great. Sarah Service.
Hi, my name is Sarah Servid. I work as one of the P&T clinical co-coordinators for OSU Drug Use Research Management Group. Hi, and Deborah, I go by Dean Weston, and I'm the Pharmacy Program Policy Advisor with OHA.
Great, Dee. A little bit of technical difficulty with your microphone. It kind of sounds like you're in an aquarium, so just a heads up.
I also, by the way, live in an aquarium. No, is it any better now?
On my end, I still hear it, but it's not horrible.
Okay.
Sounds like I'm watching SpongeBob.
No?
All right.
Okay.
Brandon?
Brandon Wells, Pharmacy Program Analyst, Oregon Health Authority, for fee-for-service.
Super. Thank you. Thanks for the reminder for the staff, for the introduction. Got a strong team that does a lot of work behind the scenes to make these meetings go forward and do the clinical work for the OHA. So with that, Dee, we will turn it over to you for the department update.
All right. Well, I'm not sure. Are you able to hear me well enough? No. No. I'm going to call in, so check now. Okay? Just a moment. Hear me. Yeah, I think we can hear you. You're not able to hear me.
Yes, no, loud and clear, Dee. You sound great. Thank you.
Oh, okay. Oh my God, I'm so sorry. Okay, well, so department update. You've been waiting patiently, and I don't have a lot to say, but I'll go through as quickly as I can, not to get more time. As you can tell, I'm filling in for Trevor, and will do my best. You can go on to the next slide, actually. Thank you. So I kind of revisiting his slides from last time and updating them as needed. The staffing assignments, they're just a couple little additions. First of all, Trevor, as I said, I'm filling in for him. Why am I filling in for him. Well, that's because he's been assigned to work with the COVID-19 vaccination project. But never fear, he is still the Oregon Prescription Drug Program and Pharmacy Purchasing Director. My role is still as the Pharmacy Program Policy Advisor and just backing up for Trevor as needed. Amanda Parrish is with the Mental Health Clinical Advisory Group and is the Mental Health Clinical Coordinator for that group. Brandon Wells, I think last time Trevor described him as the interim fee-for-service Medicaid Pharmacy Operations Manager, and I am pleased to be able to finally say that he is the fee-for-service Medicaid Pharmacy Operations Manager. Got confirmation that is finally official, though he's been doing it for several months now. It's not really news to anyone who has been working with him. He's doing a great job and learning a lot. Jennifer Bowen, Executive Support for Delivery System Innovation Pharmacy Section. I think we are also in the process of hiring a clinical pharmacist, and we haven't started with interviews yet, but I understand that there were a number of applicants, and we'll be meeting with them later on, I think this month. And next slide, please. For the Mental Health Clinical Advisory Group, they recently published bipolar disorder clinical practice pearls for treating special populations and people with co-occurring disorders. That has been published now, and in development currently are more bipolar disorder materials, including a screening tool, as well as major depressive disorder materials. Next slide, please. All right, and the main reason I'm here is to talk about and to thank Dave Pass for all his years of dedication and assistance to OHA and to the people of Oregon. Dave is the former director of the Health Resources Commission. He helped form the P&T committee and is an original member. And I'm told he is the owner of a Real Deal red Swingline brand stapler. And I hope that those of you listening to this understand that reference. If not, comes from apparently one of his favorite movies, a very good movie, Office Space. And before I turn it over to a special guest who will be doing a more proper send-off for Dave, I promised Trevor that I would relay his gratitude and his appreciation. Trevor wanted to be sure that Dave, that I tell you that he's sorry he couldn't be here virtually here to say this himself, but he wanted me to convey to you that he's learned a great deal from you over the years, and he wishes you well. We also heard from Pam Curtis, who's now with the Center for Evidence-Based Policy. She had many kind things to say about you. She says that you are an innovative thinker and usually a couple steps ahead of your colleagues. You're one of the pioneers of bringing evidence as a rational ingredient to pharmacy decisions. She says your contributions were thoughtful, innovative, and you made hard decisions fun. I think it's pretty fantastic. And finally, you're an original DERP member from Oregon, original P&T member, and original thinker and innovator. And with that, I hope to turn this over to a special guest. Darren, are you on the line?
Can you hear me? Yeah, Darren, thank you for joining us. And Dave, I see you online. Are you able to unmute yourself in case you want to share any comments as we go here? We really, appreciate all your work.
Yeah. Can you hear me?
Loud and clear.
Okay, well, I also had a Milton Wadham's nameplate, too, but but I still have the statement.
All right, Darren. All right, for those that I haven't had the pleasure of meeting in person, my name is Darren Kaufman. I'm the former director of the Health Evidence Review Commission. I got an email a few weeks ago from Trevor asking if I would take the lead in recognizing Dave during his last P&T meeting today, which I was more than happy to do. Now, I know that Dave has been phoning it in on these meetings long before the pandemic began. So if you haven't met him in person, that isn't a picture of Dave that we had up on that previous slide. that in fact is Milton Wadhams from Office Space, but kind of had to go. Somehow Dave has successfully kept himself off of the internet, so we didn't have anything to steal from. So the first thing I did for this very important project was to come up with a catchy name, which I'm calling the Path Send-Off, or TPS for short. Now, unfortunately, this happened to get put on my plate right as I was in the middle of binging all 6 seasons of Schitt's Creek on Netflix. So next slide, please. So instead of doing a full report on this project, all I was able to finish was the cover sheet for this TPS report. Dave, I'm sure you can appreciate this. I guess I should have come in on Saturday to finish that one up. Yeah. Next slide, please. So I worked with Dave for a few years back when we were both with the state, and I sat in the cubicle right next to him. This is, a pretty good approximation of us speaking back and forth on a daily basis, and there is his red swing line stapler there. But back in the later 2000s, Dave was the director of the Health Resources Commission and overseeing the development of the drug reports prior to the formation of the P&T committee. I was director of the Health Services Commission and only had the prioritized list of health services to worry about at that time. Then in 2011, he somehow was not only able to offload the drug reviews to this committee, but saddled me with the health technology assessments that the Health Resources Commission had been doing as well. So I think you can probably join me in congratulating Dave on his successfully sticking us with all the hard work there. But on the serious side, Dave did act as a great resource for helping me get the Health Evidence Resource Commission put together. Most notably, he came up with the acronym HERC, short for Hercules, which was for all the extra workload we'd be carrying at that point. But he did follow through with the work on the drug reviews by serving as you heard, one of the founding members of the P&T committee and serving for the past 9 years. So definitely appreciative to him for that. And by the way, Dave, the other thing that I was able to do after you left was go through the boxes and boxes of DIRP reports and HRC reports that had to be filed and put away to the state archives. So you're welcome on that. Thank you. Next slide, please. So I guess Trevor did actually go to Dave and plead with him to stay on the committee even longer, but I guess he politely declined. Next slide. Now this is the part of the meeting where we would normally be passing out cake to mark the occasion, but of course we unfortunately can't all do that together today. So next slide. So instead I put together some flair that can be cut out and worn to celebrate Dave. Feel free to print this out and wear it for the remainder of the day. Next slide. So anyway, just I think some of you are on mute, but join me in giving Dave a round of applause for being such a great resource to the committee and the state for all these years. So thank you, Dave.
Thank you.
And next slide. And so I hope you'll be able to travel to a warmer climate soon after your recovery and the pandemic subsides. And now that you're not poring over the DIRP reports, you can, spend more time at your leisure. However, knowing you, I bet instead of lounging at the beach, you'll probably be holed up inside a classic automobile convention somewhere. So, but thanks again, Dave, and I hope that both Mary and I get to cross paths with you again soon.
Absolutely. You got to get down to Tucson, which, by the way, is where I am, and somewhat dressed like Milton there.
Okay.
And our weather's not quite as good as it is up there. We're only 72 today. So.
Okay, yeah.
Well, thank you all so much. Honestly, it's been an absolute pleasure. The last year's been a little difficult for me as far as scheduling and timing once we switched our dates around, but I have actually kept very close track. I kind kind of feel like I'm walking away from family here, and I will miss it.
Dave, this is Bill.
Hey, Bill, how are you?
I'm good. And I'd like to thank you for getting me involved in this and helping me to learn the ropes. And I also
think it was mutual.
to thank you for all the astronomy advice. And offline, I'll tell you about the telescope I bought.
Oh, absolutely. Let's talk.
Clear skies in Tucson.
Well, if you get on down here, I am in the process of putting together an observatory. So.
Oh, wow.
Yeah.
Dave, I can't thank you enough for your years of service, for your mentoring for me and helping acclimate me to Oregon and the prioritized list. And I met you originally when I was in Montana as a member of DERP when we joined, and you were already a stalwart there. So I just, appreciate your friendship, and I'll miss you on this committee, but hope to stay in touch. I really appreciate you.
Absolutely, Roger.
All right. Well, thank you very much, Darren, for showing up here. Really appreciate it. And with that, do we have one more slide? Okay, we'll do the ledge updates in a second. Again, big round of applause, Dave. Thank you.
And before Darren drops off, I know how to get in touch with everybody. I think I've lost your contact info. So offline, let's work that out.
All right, happy to facilitate any way I can. You both have erased yourself from the internet. Full credit.
I'm there. I'm just not there under my name.
All right. Thank you.
Thank you all, and really, it's great work that y'all do, and I know that I've left my position in great hands with Kat, who I've also known for many years. So, continue the great work that you guys do.
Will do. All right, with that, Dee, we'll turn it back over to you.
Yeah, now back to kind of the boring stuff, but just very quickly, of course, we're in a legislative session, which may continue through to June 28th. There's one main agency bill that we're watching very closely. We sometimes call it the Pharmacy Omnibus Bill, House Bill 2080. It does a number of things. It establishes a new Office of Pharmaceutical Purchasing, or OPP, we're calling it for short, because everything has to have an acronym, of course. It also clarifies agency authority related to the support for the preferred drug list and support for the prioritized list. And it resolves a negative rule determination that a number of years ago determined that CCOs cannot have a separate preferred drug list. As introduced, this bill would require CCOs to recognize and adopt a partially aligned preferred drug list, but OHA is working to request amendments to this bill in order to make a few changes that include, instead of resolving the negative rule determination through a partially aligned PDL, instead of that, authorizing CCOs to have independent preferred drug lists, and then directing OHA to work with interested stakeholders, including CCOs, to determine what the future of the pharmacy program should be, what is the best way to improve member and provider experience and contain costs. So we'll see what becomes of that, but that's probably the bill that we're watching most closely. There are other bills, of course, that we're also tracking, including House Bill 3045, which I believe is partially requested by NAMI, so it involves mental health, drugs, and other aspects of that program. And then there are quite a few other bills that aren't quite as, that I'm not tracking at least, as closely due to the priority level. But that's the basic overview of what we're watching most closely right now. Are there any questions about any of that? Nope. Okay. Well, we'll certainly be reporting again maybe toward the end of session, because certainly House Bill 2080 could have some indirect impacts to the PNT, but nothing that would fundamentally change your roles. I see. All right, thank you.
Great, thank you, Dee. The next part of the agenda is the consent agenda. These are topics that we've included in the packet. Some minor modifications to PNT methods and operating procedures. As a standing placeholder, we have an orphan drug PA update, an oncology PA update. We add new drugs that fit the criteria to those criteria so that they can stop prior authorization. We also add literature scans. In this case, we did an anticoagulant literature scan. Please understand for the committee that if it's part of the consent agenda, there was no new clinical information that necessitated us providing an update to you verbally. So we include it as part of the consent agenda so that we can go into executive session to discuss confidential pricing. So with that, I just want to see if there are any of those topics that the committee wished to take off of the consent agenda to discuss. And hearing none, we do allow public comment for consent agenda topics, and we do have one member, Sami Nasrawi with Alm Pharmaceuticals. You should be able to unmute yourself.
Thank you, Roger. My name is Sami Nasrawi. I am a pharmacist and medical outcomes science liaison at Alm Pharmaceuticals. So good afternoon, everyone. I know there's no formal discussion of Oxlumo today, which is lumasiran, but I wanted to take the opportunity to very briefly address primary hyperoxaluria type 1 and Oxlumo for about 2.5 minutes, given its addition to the orphan drug policy and any downstream considerations or discussions that may occur. And I just briefly, before I proceed, I wanted to check to see if I could take that opportunity to do that over here. So, very briefly, primary hyperoxaluria type 1 or PH1 is a rare metabolic disorder. It's caused by a genetic defect in the liver that leads to the overproduction of oxalate by the liver. So oxalate is very poorly soluble. It cannot be metabolized. It's primarily excreted through the kidneys, where it combines with calcium to form insoluble calcium oxalate crystals. And the accumulation of these calcium oxalate crystals in the kidney, they can cause direct damage to the kidneys. It can also cause nephrocalcinosis, which is where calcium oxalate accumulates in the kidneys, and also causes recurrent kidney stones. And all of this leads to renal impairment that progresses to end-stage kidney disease over time. And as kidney function declines, the kidney cannot effectively clear the oxalate made by the liver, and as a result, systemic plasma oxalate levels in the body start to rise, and this potentially leads to a condition called systemic oxalosis, where now you're getting calcium oxalate crystals that get deposited throughout different organs in the body. So it is a serious disease that is potentially fatal if not adequately treated. Prior to the approval of Oxlumo in November of last year, there were no FDA-approved treatments to treat PH1. It's a very rare disease with an estimated diagnosed prevalence of about 1.5 to 2.5 per million in the United States. It affects both children and adults, with over half of patients diagnosed in early infancy or later in childhood. And the rarity of this disease and the non-specific disease presentation, it often results in a delayed diagnosis, with up to 70% of adult-onset patients being diagnosed only after they've progressed to late-stage CKD or end-stage kidney disease. Liver transplant is the only means to correct for the underlying genetic mutation in the liver and to normalize that high oxalate production. And this is often done in tandem with a kidney transplant when needed to restore lost renal function. So given the current PH1 management landscape, there's an urgent need for a therapeutic option to substantially curb oxalate overproduction, which is the cause of progressive kidney failure in PH1. And so Oxlumo, or lumasiran, is a novel small interfering RNA therapeutic. It's indicated for the treatment of PH1 to lower urinary oxalate levels in pediatric and adult patients. It's administered subcutaneously with quarterly weight-based maintenance dosing. And in 2 phase 3 studies, Oxlumo demonstrated statistically and clinically significant reductions in urinary oxalate while having an acceptable safety profile. And the most common drug-related adverse events were injection site reactions, all of which were transient and mild in severity and did not lead to treatment interruption or discontinuation. So thank you very much for your time.
Great. Any questions for Sami? Okay. With that, we need a motion from the committee to accept the items in the consent agenda.
items in the consent agenda?
Second.
Stacey, I'm waiting for you. All in favor?
Aye. Sorry, Roger. I was just going to chat in. Am I supposed to be doing this already?
Yeah. Well, we haven't talked about it. You're brand new to this, but you can take the lead, or unless you want to listen to me, I'll chime in as well. But
I'm going to let you do it this time because I was totally not prepared. So if you don't mind, I will pick up the next time if that's okay.
Happy to do it. So, any opposed? Great. Motion passes. So the P&T committee also serves as the DUR board, which is federally mandated when states elect to cover prescription drugs. DUR board meetings have to occur quarterly. So we focus one meeting each quarter on DUR activities. And those include a number of reports we present. So I'm going to briefly go over the quarterly utilization report. These are posted to our website, so they're available so you can look back historically and see changes over time. This is really the only meeting where I'll get into this a little bit. We've briefly gone over it with the new committee members, and those returning members have seen this before. But just a few things I was going to point out from this report. You'll see, first of all, the top row, that the latest month reported is June of 20. The reason that we're looking 6 months back is because the majority of our lives are in coordinated care organizations. And for us to be able to get their encounter data and report on that information, and also to collect rebates and report on how much we collected, we need to look back that period of time. The top row will show you that there's a little over 1 million lives in June in the OHP, and then we have a rolling average, so just over 1 million lives. Then we break out the different lines between fee-for-service and encounter. Encounter is representative of the CCOs. So almost 100,000 lives in fee-for-service, large number, we have the Medicare lives as well, and then the CCOs have the lion's share with 963. The next line down, we start to have gross figures. Draw your attention to, April, May, and June. Those would be the 3 months in the second quarter. You can see we spent, roughly $256 million. Just bring that to your attention because I'll be referencing that in just a couple minutes. And then you also notice for the mental health carve-out drugs, as an example, in March, you'll see we ticked up from 8.6 million in February to 9.5 in March. Just wanted to bring to your attention, as COVID hit, we encouraged pharmacies to fill drugs early and also to fill larger quantities of maintenance supplies. So that artifact can show up in our reports. So in this case, we had a larger spend because we saw some of those early refills, and we also saw some larger quantities. So different items like that can translate into these reports over time. Similarly, you'll see that further down in the physical health drugs for fee-for-service, so $3 million, so a couple $100,000 uptick again, March and April. And then down in the encounter physical health, they too had a slight uptick, so 65, they were doing some of the same actions as they tried to encourage their members. Next page. So we put together a pie chart. These are the year amount paid, just so we have a visual, shows you the lion's share, 2/3 of the spend for the OHP is in CCO encounters. So that's the members that are being paid by the CCOs. And then the mental health carve-out, about 10%, but again, that's paid exclusively by fee-for-service. So it gives you a relative spend. We'll go down. All right, we'll go to the next slide. So this is where we report rebates. As I mentioned, in the quarter, so 2020 quarter 2 was representative of 3 months, and we did spend it from that first page, about $256 million in April through June. But we also invoiced for rebates. So as an addition of a manufacturer participating in Medicaid programs to get their drugs covered, they have to sign a federal rebate with the government and offer essentially their best price to Medicaid programs, and those come in form of rebates. And so the state invoiced for almost $110 million in the second quarter. And that translates down then to our quarterly net costs, so $148 million. So again, if you take that first page, $256 million, take away the rebates, that's how we come up with those numbers. Then we also, this page shows you the SR, indicates supplemental rebate, and that's one of the important jobs that this committee does for making recommendations to the OHA. In executive session, we disclose to you both federal and supplemental rebates, confidential information, so you can make recommendations for a preferred drug list So you can see in the pie chart, while not a large percent, still significant in the supplemental rebates the state is able to collect. Next page. We start to get a little bit more granular, so we have per member per month, total number of claims. We try to break out and see what the average cost per claim was over time. They stay pretty stable. Sometimes, for example, like in the mental health drugs, when certain drugs go off patent, Abilify comes to mind. While it was our number one spend for a long time, when it goes off patent, it changes not only our generic utilization, but it also changes the cost per claim. And so those data points are captured here, but it also gives you a trend. So as I'm looking at the gross amount paid per claim for generic multi-source, you can see over a period of, from July of 19 to June of 20, staying pretty stable, about $19 a claim. So it just gives you some assurances with our AAC and the drug complexion that's being prescribed, how we have some stability in the program. And then the mental health carve-out, you'll see pretty stable again, $1,000 per claim. Again, representative of a lot of things like long-acting injectable antipsychotics. Those can cost a little bit more, so those might make those costs a little bit more. We track the generic drug use percent. We have mandatory generic substitution, so we like to see, riding around 90%. One of the initiatives that we do is sometimes prefer the brand name drug over the generic. Again, I'm kind of setting the stage for something we'll discuss further in our reporting with you, but that can work against that where you don't have as much generic utilization, but it's the net cost that we're looking at. And then the PDL percentage. So down at the bottom of the page, you'll see our preferred drug use. We're averaging about 88%, which is great. But you will notice that the mental health drugs are lower than that at 81%. And that's a function partly because that is not enforceable. We have voluntary non-preferred drugs, but can't stop them from prior authorization like we do with physical health drugs. And so you'll see that the generic percent is a little bit lower there. Next page. We also then break out, and this is more for the recent time period, our top 40 drugs. This is all the drugs paid by the fee-for-service program. So what you'll notice is that these are predominantly mental health carve-out drugs, antipsychotics and antidepressants. We do have some other classes that will jump up, so some physician-administered drugs. So line 16 is Spinraza, 2 claims, but it makes it up to the number 16 drug spend. Then some of our classes, like HIV, they'll also get on the list. ADHD will also make it. Unique to the ADHD class, a couple of the drugs are considered carve-out. Atomoxetine is one of them, caffeine and tunib as well, so that's one of the reasons it makes this list. Next page. And then at the request of the P&T committee, they asked us to break this down by physical health drugs. And so we have an extract here of our top spend by drugs that are considered physical health and not just a carve-out. We're only paying for the fee-for-service members. That was a quick overview. Invite the committee to review these. Any questions at this point? Anything you want me to go into any more detail on? Okay. With that, DUR, drug use review, is broken out into prospective drug use review, retrospective drug use review, and education. And so prospective happens at the point of sale, and I'm going to turn it over to Rich Holsapple with Gainwell Technologies.
Thank you. So prospective DUR is done in the point-of-sale claims processing system, and it's done at the time that the claim is submitted. Utilizing data that we have in the MMIS system, it will identify whether the drug meets one of these alerts based on it being a severity level of 1, which is the highest level of severity. Those parameters around the ProDUR alerts are sent to us through First Data Bank, so we maintain those in the system. This is a list of all the prospective DUR alerts that are built into the system. The highlighted ones are the only ones that we actually deny claims and require the pharmacy to respond with appropriate intervention and outcome codes in order to override the alert and get a paid claim status. So the others are just informational for the purpose of the pharmacy to use, but we still pay the claim. So the main one we see the most of is, you can see there's the early refill, which is set at 80%, which means that on a 30-day supply, it has to have been at least 24 days since the previous fill before we allow the next fill. Otherwise, it'll hit the early refill. So we, by far, 68% of our DUR alerts are the early refill. Overrides, cancellations, non-responses, that's how the pharmacy responded to this denial. So only 17% of them actually get overridden by the pharmacies for various reasons. We have a few that get canceled where they actually submit they've canceled the fill. And then vast majority are just not responded to. So if we go to the next page, on the early refill ones, I kind of pull out the highest volume ones and some other ones to note. Usually by looking at this particular list of agents, we get a general idea that it's a pretty low percentage of alerts compared to the total claims for those drugs. They're all under 15%. So we don't see an overusage on any particular agent in particular, any particular agent. The alerts that are overridden, those are can be a little bit misgiving just because of the volume of claims. Like if you look at the controlled substances there, it says that 87% of them were overridden. Well, we only had, that's 8 claims out of 1,000. So it's only 0.7% of the actual claims hit early refill. So it may look like it's a high percentage, but that's because the volume of claims is low. Because those would just be fee-for-service, where the mental health drugs are the whole Medicaid population. If we go to the next page, this is an overview. When the pharmacy does override an early refill, they do have to indicate with the reason code as to why they're overriding it. Very small percentage is because of lost or vacation supplies. A vast majority are therapy or dose changes. Medically necessary seems to be a common one. The emergency disaster one, we've been seeing a lot more of that between COVID and wildfires. So people are getting their prescriptions filled early in order to minimize their traveling to the pharmacy. So we've seen an uptick in that this year. And then there's one more page, which is kind of a new one. The CMS annual report does ask states to indicate their cost savings related to DUR activities. By far, it's more the retrospective DUR initiatives and some of the other DUR limits that we put in the system that can create the cost savings. It's pretty hard to identify what true cost savings we have with just the pro-DUR alerts. So the methodology, which I have here, is the only way we can actually say this was truly a cost savings because of the pro-DUR is if the pharmacy actually responds to the alert that they've canceled the prescription, which we saw earlier was only 238 that they actually responded as being canceled, and then it's not later filled before it's actual true due to be refilled. So these are the cost savings that we garnered from the pro-DUR early refill alert and the pharmacy canceling the fill due to that alert. So any questions?
Great, thank you, Rich. So again, after ProDUR, we do retrospective DUR. Obviously, we're looking back at claims and take action. These reports are not posted publicly, but they're included in the packet quarterly. So we'll turn it over to Dave Engen. If you're following along on the packet online, I believe this is on page 79.
All right, thank you, Roger. So since this is the first time of the year, we'll be talking talking to you about this as a group. The new folks, I want to spend a bit of time later in executive session to help kind of orient you on our reports by giving specific pricing details and kind of show you how we consider certain of these initiatives as opportunities to kind of set the stage for the rest of the year. But for this report right now, the first report we're sharing with you is the formulation switch or change form. And you'll see fluoxetine, tabsicast, and vaccine tabsicast. So basically this is where prescribers are messaged about switching to a more cost-effective formulation. And we distribute faxes with pre-printed customized change forms. With fluoxetine, just 23 patients identified. So in this one, we may have reached a point where we've maxed out the utility, at least for now. Start difference when it was rolled out a while back. But we're still getting plenty of venlafaxine switches. You'll see there are 59 switches out of 99 successful faxes. And for both those initiatives in quarter one, if you kind of compare the numbers, prescriptions are being changed roughly half the time for those faxes that are sent successfully. So just remember when you look at the cost savings, that accumulates. And it accumulates, as the year progresses and patients refill, we track those savings for the 12 months in the year. So that number will change over time. If we go to the dose consolidation, another cost savings initiative, this is where we target most of the mental health carve-outs, mostly because of the large utilization. It's covered by fee-for-service. Prescribers, once again, they're notified to consider consolidating certain flat-priced drugs, 2 tablets to 1 in appropriate circumstances. These are also distributed as faxes with a change form. There's 20 or so agents that are in this program, and as opportunities flag, we message a prescriber to please consider consolidating the dose. Once again, these accumulate over time, and as the drug is refilled over the year, that 700 can be many more times that amount for the patients in that particular quarter. We'll discuss more of that later. If you look at expert consultation referrals, that's antipsychotic use in children. These are referrals to OPAL-K to ensure safe prescribing for children on multiple antipsychotics. So this is more of a safety initiative, not really focused on savings per se with these, but this was a policy evaluation that was presented to you at an earlier date, and we present these types of things on a regular basis, so I can address those details, especially once it's up for review again. But you'll just see there, although there's a lot of patients that are identified, the majority aren't sent for referral because they might have a PA already in the system, or they might have just been for short term. But there are some times where there's key red flags, no metabolic monitoring, or they're on more than 6 months of therapy on multiple agents or certain high risk indications. So we would refer those, and the OPAL-K's bandwidth isn't infinite, so we refer the most severe cases first. If you go to the non-adherence, the next page, for antipsychotics and people with schizophrenia. Once again, this is another recent policy evaluation, and those patients that have been on therapy for at least 3 months, but now there's a 2-week lag in filling their prescription, and the patient has history of ER visits or hospitalizations in the past 2 years. The docs will get a notice on that and can act on that. You'll see that half the patients identified end up getting their prescription filled or a similar prescription once they're notified. So 180 days. You can see the numbers and review the letter sent on that. The lock-in, these are, once again, controls that we have in place. But these patients will go into a profile and get reviewed. They could have overlapping quantities of, drugs with potential for abuse or misuse, maybe escalating over a short time period. So, we do have controls in place. There's a pretty stable population. New members are enrolled into CCOs. So, when we deal with this, it's more, as I said, as more of a kind of a broad scale intervention. So, our opioid criteria, for example, all our long-acting opioids require PA. Our short-acting opioids, we limit to a 7-day supply, 2 of those. And, even benzodiazepine and opioids, they're not allowed with our criteria, or, they have to have reasons why. The patterns, we use the utilization control, so it's not surprising that we don't have a lot of new members for lock-in, but we do lock them in when it's necessary. The last one is just the safety net, and you'll see different ones there, combination opioids, sedative, ICS-LAVA, TCAs in children. And we've also recently added oncology denials, and the facts they're sent to the prescriber of an alert. We still have quite a few opioid sedative combos being flagged, but the good thing, almost half of those result in a discontinuation soon after the messaging. Once again, we don't track costs on these because the cost might increase, but the hope is improved patient safety and overall decrease in emergency room visits and other medical related costs. So focus more on safety with that. But we can get in more details at some point, and like I said, we'll be revisiting some of the pricing, how this relates to pricing in executive session, at least in part. So,
Great, thank you, Dave. Any questions for Dave on Retrodur? Okay. An additional component.
Yeah, this is Russ. There's a bar for these Produr and Retrodur things in terms of the dollar amount that is considered high enough to make paying people to do the things worthwhile. And can you remind us what that is?
That was actually one of the discussions that we were planning to have in exec session today. So,
gotcha.
So we can definitely cover that in more detail with some specific examples. But that's a great question.
Thanks.
Yeah.
Okay, another component of DUR is education. In addition to some of the lettering that Dave had mentioned here in the faxes, we achieve that through our newsletters, and we'll turn it over to our editor, Kathy Centena.
Great, thanks, Roger. Today we'll be referencing a couple newsletters. One was published in August and the second one in September of last year. The first one that you see there is the disease-modifying antirheumatic drugs for management of rheumatoid arthritis, authored by our own DM Red. And this is a really good overview of 3 new agents: seralulimab, baricitinib, and abadacitinib. I hope I didn't butcher those too much. But anyways, I encourage you to take a look at that one. And then the second one was a cardiovascular outcomes newsletter that looked at the efficacy and safety of the newer therapy classes for type 2 diabetes. And this was based on the findings from the Drug Effectiveness Review report. And they looked primarily at LT2 inhibitors, DPP4 inhibitors, and GLP-1 receptor agonists, and their effects on cardiovascular outcomes. So that was also a good one to take a look at. You might have seen that we posted a recent newsletter here in January on COVID vaccines. And then our next newsletter coming up in February will be on antidepressants. Again, we do send our newsletters to the committee as drafts before we post them, and we really appreciate all your comments and your feedback on them.
And then, of course, we're always open to new ideas via email or, right now, if you have any thoughts on newsletter topics that would be informational for providers, we always look forward to getting those.
Great. Thank you, Kathy. Any topics come to mind at this moment? Super. Well, thank you all again. We're going to touch on some of these topics. We don't generally touch on DUR in exec sessions, but because they're underpinned by a lot of confidential pricing, we thought there was an opportunity here at the beginning of the year to have that conversation so you could see some of that pricing, talk about some of those thresholds. So we will have that conversation. Again, we don't conduct business in executive session when it's clinical in nature, but we can't disclose rebates and confidential pricing. So we wanted to show you some of that information. So with that, we'll move over into the preferred drug list component of the agenda. People following online in the packet, we're turning to page 90, and we'll do the Duchenne muscular dystrophy class update and turn it over to Sarah.
If you bear with me, I'll bring up the slides real quick. All right. So the purpose of this class update is to evaluate placement therapy for a new agent in this class, pitolisant, which was recently FDA approved. Just as a little bit of background, Duchenne's muscular dystrophy is a rare X-linked genetic disorder that's caused by an absence of functional dystrophin protein. And patients with Duchenne's muscular dystrophy experience progressive muscle deterioration, which eventually leads to loss of ambulation and decreased muscle strength. There is no curative treatment for Duchenne's muscular dystrophy, and current therapy focuses on improving symptoms, enhancing quality of life, and decreasing disease progression. A lot of the care is supportive and non-pharmacological, but current guidelines do recommend initiation of corticosteroids as a first-line treatment for ambulatory children with decline in motor function in order to delay loss of ambulation, preserve pulmonary function, and reduce risk of scoliosis. There was one systematic review that was included in this update. A DERP report was updated, which evaluated deflazacort compared to prednisone in 2020. They didn't identify any new comparative randomized control trials in this update. There were 4 randomized control trials of poor methodological quality that were all included in the original systematic review that were re-reviewed in this report. Overall, there was no difference in muscle strength or motor function outcomes between deflazacort and prednisone for patients with Duchenne's muscular dystrophy, and that was based on insufficient evidence. Similarly, there was insufficient evidence to evaluate comparative differences in adverse effects between deflazacort and prednisone. Compared to prednisone, deflazacort may be associated with less weight gain, but an increased risk for cataracts and fractures. And then getting into the new drug evaluation for pitolisant. It was FDA approved for patients with mutations amenable to exon 53 skipping, and the goal of this therapy is to modify mRNA splicing in order to increase the amount of dystrophin protein in cells and thereby correcting the underlying disease process. It's the 3rd drug that's FDA approved with this mechanism of action, and it's actually the 2nd one that's approved for patients with exon 53 skipping. It was approved based on a phase 2 dose-finding trial that had high risk of bias and included 16 patients. There was a 2nd trial that was conducted in Japan that wasn't used for FDA approval because of the inadequacy of methods that they were using to evaluate dystrophin and measure the quantity of dystrophin. The efficacy trials comparing pitolisant to placebo haven't yet been completed, and this trial that was used for FDA approval was a single-arm trial. So the primary efficacy outcome was change in dystrophin protein evaluated by Western blot analysis. There were several secondary outcomes that evaluated dystrophin levels with different
different methodology, I guess. And at 24 weeks, patients treated with pitolisant demonstrated a mean improvement in dystrophin from baseline of about 5.3% of normal to 5.4% of normal for patients treated with 80 and 40 milligrams per kilogram every week. There was insufficient evidence that use of pitolisant affected any clinical outcomes, including symptoms, muscle or pulmonary function, quality of life, or disease progression. Overall, we don't have a lot of long-term safety for pitolisant. At the time of FDA approval, there were 23 patients that had been treated with this drug. Only 16 patients had been prescribed it for longer than 12 months. It has very similar safety labeling compared to the other drugs in this class. It includes warnings for renal adverse events based on data from animal studies. And it is administered intravenously weekly. And so like other targeted therapies for Duchenne's muscular dystrophy, there's possible risk for serious infections related to use of the indwelling catheters that's needed, particularly if the patient is receiving chronic corticosteroids. And typically chronic corticosteroids are a first-line treatment for this disease. There are a lot of trial limitations. Like I mentioned, this trial had high risk of bias. It was a single-arm trial with use of a historical comparator, but that historical comparator is really inadequate to compare efficacy for this drug. They had an open-label study design after 4 weeks. It didn't evaluate a lot of clinical outcomes compared to placebo, so we're really unsure about the efficacy of this drug. And like I mentioned earlier, I don't have a lot of long-term data to evaluate safety. So the recommendations are to update the PA criteria to include pitolisant, and I'll go over that in just a little bit, and then review costs in the executive session. So the PA criteria changes that we're recommending, I've highlighted them here, but you can see the full PA criteria in the packet. One is just to add a note to question 6 that deflazacort may be an option for patients with clinically significant weight gain if they had weight gain with prednisone. And then we are just reordering the questions in the criteria to move the question regarding continuation of treatment to a little bit later in the criteria to improve the flow. And then this is where we're adding pitolisant to the PA criteria. Question 10 asks if they're being treated with 2 or more targeted therapies, and then to deny the request if that is the case. Since these drugs have the same mechanism of action, they shouldn't need to use more than one. And then question 11 references renal function as recommended per label. And then similar for the renewal criteria, adding this drug to the renewal criteria with the recommended renal monitoring. And I'd be happy to take any questions.
I think one of the things that I was wondering about is there any information about differences between patients, who were treated with one and then switched to another, or, vice versa? And any guidance on which one, if someone uses one of these, of the targeted exon skipping thing, is there any benefit to changing between one and another? Is kind of the question. Like, what would we do in a situation where somebody said, "Oh, well, they were on this for a while, and now we're going to try this one"?
That's a good question. I don't know that we have any data. I'm not aware of any data that looks at that particular type of switch or has studied that population.
We do have public comment that maybe will address that, Dr. Helm, so we'll see when we get to that point. Any other questions for Sarah? Okay. With that, Tracy Copeland, I have given you the ability to unmute yourself. Can you hear me?
Yes, I can. Can you hear me?
Can hear you loud and clear.
Thank you.
You have, the floor is yours.
Thank you. Good afternoon. Thank you for your time today. My name is Tracy Copeland, and I'm with Medical Affairs at Therapeutics. Just a couple of quick to make. It pertains to the last question that came up. As referenced even in your clinical criteria that was developed, it is difficult to cross-compare between exon-skipping therapies and even clinical trials due to the fact that there are differences in the populations, the genotypes, and a lot of variability in the methods used for evaluation of dystrophin. So unless there were a head-to-head evaluation, that's a difficult question to answer, but I will defer that question also to clinicians that might be set up for public comment, and they can address that further from their experience. Other than that, we'd like to say thank you for the criteria as outlined, and I'm available for any questions, whether that be now or later on in the discussion, and I will defer the rest of my time back to the committee. Thank you.
Any questions for Tracy? Great. Thank you, Tracy.
Thank you.
We also have public comment submitted from Kelly Maynard with the Little Hercules Foundation. Kelly, are you able to unmute your line?
I am. Thank you very much. And I wasn't planning on speaking. I was just planning on listening in. I run a patient advocacy organization for Duchenne muscular dystrophy patients and families. And if I could provide just kind of a patient caregiver perspective to the last question, it is a really good question, and I think it's one that, I would just put into the perspective of a couple of years ago, Duchenne patients had no choices whatsoever in treatment, and now we're seeing choice. And that's really important, as going back to what the Sarepta representative said, is that, side effect profiles or non-responsiveness to one may indicate, have a provider giving an option of going to another therapy. So I would just put that out there for consideration. That's also appropriate to consider between deflazacort and, Emflaza and prednisone, is that the side effect profiles sometimes can present very difficult side effects to manage. And so having choice there is really, really important. So I'll just leave it at that. Sorry, I wasn't planning on speaking, but I'm happy to answer any questions.
Great. Any questions for Kelly? All right. With that, Sarah, I'm going to turn it back over to you to recap the recommendations in front of the committee.
So the recommendations here are to update the PA criteria as presented, and then we will be reviewing costs in executive session.
So we do need a motion to approve the clinical recommendations.
Move to approve.
Second.
All those in favor?
Aye.
Aye. Any opposed? Great. Again, we'll come back after exec session with any changes or recommendations post-exec session. Moving on to page 108 in the packet, we have the acne class update, and we'll turn it over to Sarah Fletcher.
Thanks, Roger. Yes, we did an acne class update with an NDE for a new drug called clascoterone. Next slide. Just for background, acne can include a variety of different agents as far as treatment, both topical antibiotics and systemic hormonal agents, and then oral drugs like isotretinoin. Right now, isotretinoin is FDA approved for severe recalcitrant nodular acne, and it's recommended for severe acne. And then when treating severe acne, other classes are typically used in combination, which can increase side effects, but that often is more effective than single drugs alone. And many of the classes in this medication, or many of the medications in this medication class have been FDA approved for many years. So next slide. In the class update, there were two comfort reviews. The first one you can see compared topical azelaic acid, salicylic acid, nicotinamide, sulfur, zinc, and fruit acid. I only evaluated the outcomes for azelaic acid because it's the only one on the PDL currently. The outcomes were not that there's not that much interesting evidence that would change what we're currently doing. It's probably less effective than benzoyl
peroxide, and there's likely no difference between azelaic acid, either tretinoin or clindamycin, and I believe that was topical clindamycin, and then there's significant uncertainty regarding any difference between that medication and adapalene. And as far as safety, it was unclear if there were any differences between adapalene or benzoyl peroxide, and no difference in clindamycin. And the next slide is the other Cochrane review, which was just assessing topical benzoyl peroxide for acne. And the major findings were that it may be more effective than placebo, though that was low certainty evidence, and there's minimal to no difference between adapalene, which is different gel, or clindamycin. And then safety tends to cause more continuation from benzoyl peroxide than no treatment because of side effects such as dryness and itching. The next slide is the NDE. Clascoterone is the first androgen receptor antagonist for acne, so it does have a different mechanism than most of the other agents. It was approved for acne vulgaris in patients greater than 10, and the current HERC policy for funding is acne is funded for acne conglobata, fulminans, and severe cystic acne. And right now, about 85% of the claims in this class are denied because they don't meet the funding level, but usually about 50 claims each quarter are approved, and most of those are for isotretinoin and clindamycin. The next slide. Clascoterone was approved based off the information on 2 randomized controlled studies. It was tested against a vehicle placebo cream in patients 9 years older, and they had moderate to severe acne based off the IGA, which is a standard scale for acne, and specific inflammatory and non-inflammatory lesion counts. They did exclude patients with nodular cystic acne, which is what's funded for HERC, and patients with 2 or more facial nodules. There were approximately 700 patients per study, and the duration was 12 weeks. The outcome was treatment to success defined as a greater than or equal to 2-point IGA reduction and a score of 0 to 1, which is clear to almost clear on a 0 to 4-point scale. And then they also assessed changes in inflammatory and non-inflammatory lesion counts. Next slide. For the results, you can see it was more effective than placebo in study 1 and study 2, but the overall treatment success rate was still quite low at only 16 to 18% over 12 weeks with this medication. And then the inflammatory lesion counts changed 3 to 7 and non-inflammatory 6 to 8. And the ranges for inclusion were 30 to 75 and 30 to 100. So those were not large changes in the lesion counts. The next slide. These studies did have, they were identically, the methods were identical, and so they did have some similar limitations. There was industry involvement and possible industry bias. So predominantly white participants, which may not fully reflect their Medicaid population, and most of the patients did have skin types 2 to 3 on the Fitzpatrick skin scale, which is a 6-point range, with 1 being the palest and least likely to burn in the sun, and 6 being the most tan without sun and least likely to burn. Only 18% of the patients in this study had severe acne, and they used a placebo comparison in a class that has many other options that are well established. Next slide. This clinical safety is similar to other acne drugs, with things like redness, itching, and scaling being the most common. You didn't put it on this slide, but one thing I did want to note is that in a pharmacokinetic study, 5% of the adults and 9% of the adolescents had some HPA axis suppression after 2 weeks. There were very few patients in this kinetic study, but it resolved upon discontinuation, but we don't have any long-term outcomes about HPA axis suppression, particularly if this was used in an adolescent population for a long time. And then next slide. The recommendations are to designate clascoterone as non-preferred on the PDP and to review costs in executive session. And then I have the PA in the next slide, which doesn't have any updates, and essentially the PA just determines if the patient, if the condition is funded rather than the medication. So, any questions that I can answer?
This is Kathy. I noticed there was no renewal criteria. We're going to put renewal criteria on this PA.
We never had renewal criteria on this PA, and I think it would essentially still be the same questions on, is it an approved indication that's funded by HERC?
I just wondered if we wanted to show that there was an improvement in, the acne. I mean, before we renewed it, but that's just my thought.
We could. We could talk about cost in the executive executive session if that would be worth the hassle of the additional paperwork for prescribers. But, I'm certainly open to that if the committee thinks that we need renewal criteria.
Does anybody have a sense of, and I'll talk to actually be the person who should answer this question, of how many people, when they started acne medicine for a period of time or whatever, they just sort of discontinue just because. I mean, I actually suspect that that's a fairly high rate, especially if they're not really showing improvement. The only real question would be how many people would continue to use it but then really no longer need it because they haven't had a trial off of it. And that's the question I think that Kathy's asking about on the renewal. But I don't have a sense for how many prescriptions people continue to fill when they're treating acne. My sense of the tips that I treat is that they stop a lot.
Yeah, I think side effects and lack of efficacy are big stopping points. We only have about 50 claims per quarter, and so that's not that many. I don't know how many of them are, but we could look into it, but I'm not sure that it's that great a number.
Can you explain why historically step therapy has been thought to be necessary for acne?
I think it is necessary.
Maybe I'm missing it, but it doesn't seem to be on.
No, we don't have step therapy, but to start with, the HERC funding is primarily until 2 years ago, it was just for the severe recalcitrant acne. Now it's acne fulminans and just regular severe acne. But isotretinoin is approved for that, so I don't know what you would make someone step through to get to that. And a lot of patients, because of the risk and side effects of isotretinoin, would want to start with something else that might be more appropriate. So what were you thinking as far as requiring a step?
Okay, so this PA is only
what would your recommendation
of severe acne, correct?
Right. The HERC funding is all for patients who qualify as having nodular acne fulminans or severe recalcitrant acne. And so most of those patients could already start with isotretinoin if you wanted. And if you wanted to step through something else, I'm not sure that would be necessary for most of them.
Yeah, thanks. That explains it.
I think it's probably more of a question of there's not any way to sort of make sure that the isotretinoin is not the only treatment that they're using, because there are benefits to using emollients and other kinds of things, but the problem is that they're not covered. So you don't have any way of tracking back.
We do have quite a few other agents besides isotretinoin that are preferred, and so if those are the requested agent and the patient does qualify for this based on the severity, they could start with others or combination therapy, and the PA would be approved as well. So if someone started with benzoyl peroxide plus clindamycin, that would also be approved.
This drug hasn't been studied in the only type of acne that's covered by Oregon Health Plan, so it would seem that based on the evidence that there is no role for this in the Oregon Health Plan. I don't know how we negotiate that. This is probably the best way to do it.
I think to have overarching criteria like we're proposing here, when you get to question 3, if it was the FDA-approved indication for the medication that wasn't funded, it would stop at number 3.
Okay, thanks.
All right, we don't have any public comments, so if there are no other questions for Sarah, please recap the recommendations in front of the committee.
Yes, the recommendations are to designate clascoterone as non-preferred on OHP and to review costs in executive session.
Need a motion to approve.
Okay, one question. Do we want to add renewal criteria or not? That was no consensus on that.
I think Sarah was just saying we will be talking about pricing in executive session. We wouldn't add it in executive session, but I think the prices might inform whether or not the juice would be worth the squeeze.
Okay. Got it.
So we add all in favor?
Aye.
Aye. Aye. Aye.
Aye.
Any opposed? Great. moving on, turn your attention to page 128 in the packet, and we'll do treatments for peanut allergy and leave it with Sarah Fletcher.
Thanks, Roger. So the second topic I'd like to bring today is peanut immunotherapy, and this was based off of a drug effectiveness or DERP review project summary that we had conducted last year. Next slide. The background, peanut allergy affects approximately 2% of children and adults, and it tends to persist over the lifetime. A single peanut has about 250 to 300 milligrams of peanut protein, but most patients who have allergic reactions can manifest those reactions with much lower amounts of peanut protein. To diagnose a peanut allergy, there are some objective measures you can get with a serum IgE or skin prick test that causes a wheal, but those simply identify sensitivity and can help differentiate different food products, but it doesn't necessarily equal intolerance if it's positive. So to truly identify that there's a sensitivity and an intolerance that causes a reaction, the gold standard is a double-blind placebo-controlled food challenge. The one caveat with this is that there are a lot of different protocols and assessment criteria on how much peanut protein or food protein, depending on what food you're using, to administer, what reactions are considered a pass versus a fail. So there is a little bit of variability, but in general, that's considered the gold standard, and there are some criteria from one of the immunologic organizations. Next slide. In the Oregon Health Plan right now, peanut allergy treatment is funded, and it's described in Guideline Note 203, and it requires that there has been a history of a serious reaction or anaphylaxis, that it's been confirmed that there's a sensitivity with the skin prick test or the IgE level, and a double-blind placebo-controlled food challenge. And then additionally, treatment must be done by an allergist or immunologist who's familiar with the treatment. Next slide. So for peanut immunotherapy or desensitization, there's currently no threshold on what is considered a successful desensitization, but it does rarely result in someone being able to eat as much peanut as they might want. The idea is to prevent reactions rather than being able to add it to the food or normal diet. And a product called Palforzia, or peanut allergen powder, was approved for patients ages 4 to 17 in January 2020. The dose is given, there's titration every 2 weeks, and each titration, the first time a patient takes it, has to be observed in the office of a healthcare provider for at least 60 minutes. And maintenance dosing, if the titration doesn't have any steps that have to be prolonged, would start at week 24, and the maintenance dose is 300 milligrams, which is essentially 1 peanut. There is a REMS program, and so the facility where the patient takes the medication, the pharmacy and the patient, and then the prescribers will all have to be registered, and the facility has to be able to handle anaphylactic reactions, and patients must carry an EpiPen with them at all times if they're on this therapy. Next slide. So this medication was approved in the FDA based on evidence from 2 studies, a phase 2 trial and a phase 3, and it was tested against placebo. The powder was titrated to a goal of 300 milligrams, and there were slight differences in the population. The ARC protocol, which is the smaller of the 2, had patients aged 4 to 26 with an eliciting dose of 100 milligrams, and then they had a skin prick wheal or an IgE level. And in Palisade, it was just a different age range. They did exclude people who had life-threatening anaphylaxis, so on a ventilator or hemodynamic compromise, uncontrolled asthma, and eosinophilic gastrointestinal diseases. You can see the phase 3 trial was about 10 times bigger than the other one, and then the duration of the study was slightly different. The Palisade trial matches current FDA labeling, where it was up titrated to a goal dose of 300 milligrams, and for this study, the outcome was done after achieving that dose at week 24. They continued maintenance dosing until week 52, where they got a double-blind placebo-controlled challenge. And then the primary endpoint, they both were passing a double-blind placebo-controlled food challenge. For the Palisade trial, it did have a higher threshold of 600 milligrams, which is about 2 peanuts. The next slide. And then the outcome results, those who passed the food challenge at the end were 79% for the ARC trial, and then only 19% of placebo, and then in Palisade, 67% versus 4%, and that was with the higher threshold. That was a number needed to treat of 2. For the limitations of this trial, there was financial conflict of interest among the offers. There was some differential loss to
getting desensitized in the active group dropped out due to things like gastrointestinal discomfort. There's also some limited generalizability as far as age, and then finally composite outcomes where the primary outcome was a food challenge rather than if a patient had fewer hospitalizations or epi administrations, that kind of thing. And then for the safety, you can see that the epinephrine used during the double-blind challenge was significantly higher in the placebo group, which makes sense. 42 and 53% of patients who did not get desensitized needed epi at the final outcome food challenge. But in this Palisade trial, they did report an outcome where epinephrine used outside of the food challenge, so just an everyday, was actually double in the group who was receiving desensitization. And then discontinuation due to adverse events, you can see, is also higher in the group who was receiving the peanut powder versus the placebo. The next slide. The recommendations here are to create a peanut desensitization PDL class within immunology. There's at least one other pipeline agent that we do expect that could possibly be added to this class in the future, to designate Palforzia peanut packets as non-preferred, and then to implement some prior authorization criteria to ensure appropriate use. And I have 3 slides of the PA criteria. I apologize, they're rather long, but the initial authorization would be for 12 months, with then renewal up to 12 months. And the renewal would also allow continuation beyond 17. The page 1 here follows along with appropriate funding, that it is in consultation with an allergist and immunologist, and follows FDA labeling, and that the patient does have a history of a serious peanut allergy anaphylaxis, which also follows the guideline 203. Next slide. Here, number 7, we do ask for a baseline of epinephrine administrations and hospital visits so that we can have a baseline for the renewal criteria. Number 8, that is a contraindication to this medication if someone's had circulatory shock or a need for mechanical ventilation. And then 9 and 10 are based off of the funding for 203 to make sure that this is appropriately diagnosed in patients. And then 11 is also a contraindication to the medication. And then I've mentioned before that there is a REMS criteria for this. So as long as everyone is approved in the REMS, then it would be approved for 12 months. For the renewal, we do require that the patient reaches the maintenance dosing by the end of the year. If a titration goes appropriately, that should happen by 6 months. If a patient does come into fee-for-service population while in the titration phase, they would automatically get approved without being at the main dose, so that there's no gap in therapy here. And then we do want the patients to have a reduced amount of needed epinephrine administrations or hospital or emergency room visits. And I would actually like to make a recommendation to change the wording on number 3 to decreased or absent number of epinephrine administrations, and then decreased or absent. In case a patient had been diagnosed 3 years ago, done really well on diet, and then just started this, their baseline might be 0, but we don't want it to go up. With that, I welcome any questions and public comment.
One of the things about this is, when you consider the epinephrine use or hospitalizations or things like that that are sort of outside of the, connected to peanut exposure, some people with peanut allergy have multiple other allergies. So there may be reasons why they would need epinephrine for exposure to other things other than peanuts. So removing peanuts, if peanuts are the only thing, then you would think that would reduce risks for epinephrine and ED use, hospitalization, etc. But if you have more than just peanut allergy involved, then that may not be the case. So I'm not sure exactly how to address that.
That's actually a really good point.
So add the language associated with.
Yeah, I think sometimes you have to sort of connect it to ED or hospitalization related to peanut.
Okay, and related to presumed peanut exposure.
Yeah.
Okay. Okay. We could make an edit to number 3 on that, and to I think on the second page of these slides to the baseline, because they will have at least a sensitivity to peanuts, but
but they could also have
soy and milk.
And eggs and shellfish and everything else. with access to people who are trained and qualified to be able to actually do the food challenge stuff. To my knowledge, I'm in Salem. My knowledge, there's really only one group, possibly two, that I can access for my kids, and both of them are in Portland. And one of them I can't get all my kids in. I can only get some kids in. So, although HSU has an allergist now, which is good, but that's only been in the past couple of years, and then there's another group, it's a private group. So, how do we sort of address the fact or consideration about the difficulty of being able to do the testing and treatment and so forth in all the parts of the state?
Well, that's another great question. For this drug specifically, though, there is a REMS that requires that the practitioner and the location both be registered, and so if they can't do a double-blind placebo-controlled food challenge, then they also wouldn't be able to administer this medication because it requires someone to be observed for an hour and then be able to have the resources to manage an anaphylactic reaction.
Right, and that's great for New York City. But
yeah,
also
access.
We have a rural state.
Mm-hmm.
Except for Portland.
Sarah, you asked about an allergist. Is that question 3 or 4?
It is, and it's part of the guideline recommendations for funding, but also I doubt that, it's possible, but it could be done in consultation with one of those and with a PCP if they are registered and can manage the anaphylactic reaction. But for this specific medication, the REMS is restricted to...
Right. Well, I hope that there's some consideration for the idea of telemedicine because we are living in a post-coronavirus world.
Mm-hmm. That they would need a location to go every 2 weeks for titrations.
Right. But if you...
It could be done at an infusion center or something like that.
Or it could be done in a primary care office. If you had a collaborative arrangement between you and the allergist was doing the observation, and effectively directing the care, but your staff was doing, you need epi or you don't need epi.
Mm-hmm. Right.
So I think there's a need to somewhat. There's a problem with the REMS criteria, I think, but there's a need to be a little bit creative about how this happens. That may be gone in our scope.
Mm-hmm.
Yeah, I guess as long as we're not more restrictive than the REMS criteria, that's kind of the best or the least worst case scenario.
And we're not. And the location of administration and the prescriber and the pharmacy, those are all independent registrations. So in theory, a location, if they wanted to, an infusion center or somewhere could do this if they were appropriately registered and working with, a physician who was somewhere else. But that, at least from my understanding, the REMS would be allowed.
And then the question is, what's the actual and opportunity costs associated with being a registered center too? So let's say.
Bill, did I see you have a question as well? Nope. Okay. We do have public comment from the manufacturer, Debbie Ham. She might be able to address some of these questions as well. Debbie, you should be able to unmute your line.
Great. Can you hear me?
Hear you loud and clear, and Debbie is with Immune Therapeutics.
Thanks. My name's Debbie Ham, and I work in medical affairs at Immune. And in light of what was just discussed, I'd actually like to use the time to address that first. So with the REMS program, I also wanted to clarify, because it seemed like there might be some misperception of it. There's actually no food challenge required for the diagnosis of peanut in order to be eligible for PAL-40. If you refer to our prescribing information, the FDA actually did not require that as part of our labeling information. And that was actually one of the points they did want to bring up today in terms of the committee reconsidering that requirement for the double-blind placebo-controlled food challenge. In addition, the double-blind placebo-controlled part of it is also extremely difficult for many offices, even allergists, to really do that. It's generally reserved for clinical trials where that kind of blinding procedure is required for the study rigor, which is what we had to do for our trials because our efficacy outcome was based on the food challenge results, and that's why we did a baseline food challenge that was double-blinded and also at the exit. So that was one of the criteria I wanted to ask the committee to reconsider. The other was criteria number 7 about the requirement for documentation of epi administration or hospital emergency department visit in the past 12 months. I wanted to ask the committee if that actually just a documentation was needed or if they actually had to have at least one of those in order to proceed or be eligible. Because if they do have to have a documented episode, then we request that the 12 months be removed and make it for any lifetime history for that patient. I also wanted to bring up that there were 2 recent peer-reviewed publications. One was the ARC-04 trial, which was a phase 3 open-label rollover study of the pivotal PALISADE trial. And it was published online in the Journal of Allergy and Clinical Immunology in December 2020. In one cohort, after approximately a year and a half of total exposure to Palforzia, 48.5% tolerated 2,000 milligrams of peanut protein during the exit food challenge. In another cohort, 80.8% tolerated 2,000 milligrams of peanut protein after 2 years of total exposure to Palforzia, and there are fewer treatment-related adverse events per patient year among subjects in their second year of treatment. The second was the Artemis trial. It was very similar to PALISADE and enrolled 175 peanut-allergic children in Europe, and was published in the Lancet Child and Adolescent Health in October 2020. And the results demonstrated a similar efficacy and safety profile as the PALISADE trial. And there's some quality of life results from that trial as well, but I'm running out of time, so thank you.
Any questions for Debbie? Great, thank you, Debbie. Sarah, we'll turn it back over to you to recap the recommendations.
Sure. So right now the recommendations are to create if you go back a couple slides, to create a peanut desensitization class within immunology, to designate Palforzia as non-preferred based on the clinical criteria, and to implement the PA criteria to ensure appropriate use of Palforzia with, if you'll go forward 3 slides, with the edit on number 3 of the renewal that it's absent or decreased for that one, and then to make an edit that any epinephrine administrations or hospitalizations on number 3 or in the original criteria for the baseline are presumed to be due to peanut. And as far as the public comment, the question regarding the baseline, it is just a baseline. They don't have to have been to the emergency room within the past 12 months. That's why I was making the edit to the renewal criteria for number 3. And then the double-log peanut controlled food challenge is part of the HERT prioritized list. That's why that made it into the prior authorization criteria. So those are the current recommendations as they are on the table.
Can I suggest, this is Mark Helm again, sorry. Can I suggest that we don't call it peanut desensitization as the PDL category? Can we call it oral immunotherapy or oral immunotherapy desensitization or something like that, rather than specifying this only for peanuts? Because there is a potential that we may have other agents that work on the same sort of concept that would be rolled out in the future.
Sure.
So.
All right, we need a motion to approve as edited and amended.
So moved.
First and a second. All in favor?
Aye.
Aye.
Aye. Aye. Aye.
Aye.
Any opposed? See, Stacy, you're going to have to learn that dramatic pause. Okay.
I'm taking notes.
All right, that's super. All right, continuing on, we'll do the tobacco smoking cessation literature scan and turn it over to Dave Engen, and draw your attention to page 141 if you're following along in the packet.
Okay, thank you. Yeah, so we'll briefly discuss the literature scan and get right into it. Really, there's no new clinical information to necessitate any PDL changes. But I slide, the recommendations, no changes to the PDL, but we want to look at it in light of the varenicline criteria. So if we could go ahead and do that on the next slide. The areas in red are the places that have been updated. We plan to update the coding so varenicline shouldn't hit PA unless the patient has used up the maximum units allowed. So once again, to my knowledge, this hasn't been an issue. So the updated criteria, if you look there, shows changed stat number 5 to up to 6 months. Do not require PA. And number 7, you'll see the areas that were stricken and allowing for 2 or more treatment regimens of 12 weeks duration. So with those changes, the updated criteria should have a clear path to coverage with 2 trials for all the preferred agents and would be consistent with the HERP guidance. So, that was pretty fast and straightforward, but once again, the recommendation is no change to the current PDL based on comparative evidence, and then update that PA criteria. For varenicline, allow 2 12-week treatment regimens within 1 year for 17 years and older, and then we'll evaluate the comparative cost in executive session.
I just want to clarify something. So they can get their first refills of varenicline without a PA, and then it's when the 6-month time hits that they have to go through the PA process?
They should be able to get the 6 months, correct, without hitting a PA. Yeah.
Now, do you think that we need any provider education regarding the expanded duration extended therapy, greater than 12 weeks? Oftentimes I get prescriptions for just one refill. I get the starter pack, and then I'll get the continuation pack, and they don't give a full, probably a course of therapy that's needed.
That wouldn't be, a bad idea, possibly. We'll have to discuss some good ways to handle that. Maybe could be something to public health, or maybe we could do potential newsletter, or don't want to necessarily focus on one particular agent, but maybe that could be mentioned. Do you have any ideas? Be welcome to entertain those and run it by the team.
Yeah, David, I actually wonder whether or not you could look at the number of recipients who are receiving the varenicline, and then what's their average duration of therapy. Like, how many people just fill one prescription and then don't ever refill it again? How many fill 2 months worth of treatment, et cetera, et cetera? Just look at like a frequency distribution histogram kind of presentation. And that would actually be useful for people who are prescribing, because I think that, some people do quite well with this, and some people stop it after, 2 weeks.
Right.
So it's
great. Yeah, we'll make a note of that, and we'll look into that and get back on that.
And I don't actually expect us to do anything with this, but given that the World Health Organization has said that helping people to quit smoking is perhaps the best thing that we can do for them for their overall health, and especially in my field, given the fact that patients with schizophrenia smoke rates of 70 to 80% and live for 20 or 25 years less, often directly as a result. I don't know why we have any limitations on this.
I had that as my first thought too. Yeah.
I'm going to third that. I was thinking that very same thing myself, just because, it seems to me like it's not unusual for patients to go past 6 months. I think 12 weeks for most people is actually not enough time, and I don't usually recommend patients stop after 12 weeks unless their smoking was minimal. So I actually would support that thought as well.
Yeah, we can definitely we can look at that in terms of comparing PDL agent costs and things, and talk about that in an executive session for sure, and see if everyone has the same ideas on that. So those are great points.
I think that one of the things that is or that has been shown, and I'm not sure if there's anything that's more recent than this, but nicotine replacement actually has a greater efficacy rate in terms of smoking cessation than the use of varenicline, with fewer potential compounding side effects. And so I think that was one of the reasons why when we talked about this originally, that was the thing that sort of came out in terms of the questions of continuation.
I've actually about 5 years ago, I participated in a literature review of smoking cessation guidelines, and at the time, nicotine replacement therapy was recommended as first line, primarily for cost and side effect reasons. But varenicline actually had roughly equivalent, and depending on the study that you looked at, in some cases, improved rates of actual smoking cessation. Now, but I will admit, it has been a few years since I've done a deep dive into the literature, and of course, it also depends on the population that you're looking at.
Yeah, definitely. I've addressed some of those issues in the scan, but looking at the long-term outcomes is where we kind of like to focus our comparisons, and there's not a lot of good data for any of those agents for long-term outcomes, but the data that we have, they appear to be fairly comparable.
So again, we'll be looking at the comparative costs and the confidential information exec session, and that might inform whether or not we come back into open session to discuss these proposed changes, or what I'm hearing you considering recommending about the criteria removal. So again, that'll happen in an open session, but we'll see if that's informed by the confidential pricing. Mark?
Well, yeah, I just want to know if Dee was still on the line.
She's logged in. I don't know if she's on the line.
Okay.
I'm on the line, but I'm not sure you hear me.
I just need you to hear me, because this is related to the legislative update. I mean, the thing that we know that's the actually most effective thing to stop kids from smoking and to stop adults from smoking is increases in the tax rate that's applied to the cost per nicotine unit. And so I don't know if that's something that y'all are tracking. And if there are any bills that are out that are advocating for increasing the tobacco taxes.
Yeah, it probably wouldn't come by my review, but I can keep an eye out for it. I think it should.
There was just a big increase, at least in Oregon, in the 1st of January, right? So then they increased the tax on cigarettes and started taxing vaping products. So, and that was I think that was a pretty significant increase.
Yeah, it was a significant increase, but it's still much less than the tax in Washington or California. So, yeah, we're behind as far as the coast goes. We're better than Idaho, I guess.
I did have a question. This is Tiffany from Pacific Source CCO. I'm not sure if I'm allowed to speak at this exact moment. My question was, or just really thoughts for consideration as we're thinking about the duration of this is, we already have significant issues with members being continued on medications after a particular disease state, is no longer relevant or medications that aren't needed. And I'm wondering, is there any data showing, because a lot of times what we're finding is if we were to pull the quantity limits or prior authorizations off the duration, is there anything that would prevent 3, 4, 5 years of therapy that may or may not be effective, or you don't have providers checking up to see if we're still making progress towards smoking cessation?
So again, we don't generally entertain public comment, but no, we would have no restrictions potentially, and we would want to do analysis to see what kind of utilization we have to see if those are necessary, but that would be down the road. Right now we have limitations, and so that isn't something that we have to be concerned with at this point, but it would be if the committee goes down the path of considering removal of PA criteria. So again, the recommendation is to review an executive session. I think we'll defer taking action on the proposed PA criteria changes. Any other questions for Dave? All right, let's take a 15-minute break. I'm going to put up the timer, share my screen, and with that, we'll see you again in about 15 minutes. Thank you. 15 minutes goes by quickly. We still have a bit to go through, and we plan to have a little more lengthy executive session today. So with that, we'll direct your attention to page 151 of the packet and turn it over to Sarah Servit for the antidepressant class update.
So this class update is looking at any new comparative evidence since we last reviewed this class. We last looked at it in July of 2019. And then it's also going to be focused on an FDA approval for a new indication for esketamine. So just as background for our current policy for this class, antidepressants are designated as part of they're either preferred or part of the voluntary PDL that carved out and so are paid for solely by fee-for-service. Previous recommendations in this class were to base antidepressant treatment selection on patient characteristics and costs. There's not a whole lot of good data looking at direct comparative data between the agents, and the available data that we do have doesn't show a whole lot of difference between the agents as far as efficacy. There are safety edits currently implemented for tricyclic antidepressants in children, esketamine when indicated for treatment-resistant depression, and brexanolone, which is indicated for postpartum depression. So the systematic reviews that were captured in this update, there was a recent ARC report that evaluated treatments for depressive orders in children and adolescents. They did find limited direct comparative data for drugs and insufficient evidence comparing SSRIs to SNRIs. The selective serotonin reuptake inhibitors, SSRIs, of the class may improve response and functional status for adolescents with major depressive disorder, but are associated with an increased risk for adverse events based on low-quality evidence. A Cochrane review looked at depression in patients without a response to at least 4 weeks of an adequately dosed antidepressant. There was evidence that augmentation of an antidepressant with some of the second-generation antipsychotics, particularly cariprazine, quetiapine, or ziprasidone, can improve symptom severity, but it was associated with an increased rate of treatment discontinuation. And then evidence for treatment response for these augmentation therapy or remission was mixed, depending on the agent. A Cochrane review looking at preventative use of bupropion in adults with prior history of seasonal affective disorder showed an improved number of patients who experienced a depressive episode during winter months compared to placebo. About 15% with treatment compared to 27%. 15% with treatment compared to 27% with placebo based on moderate quality evidence. And then another Cochrane review looked at use of SSRIs after stroke and found moderate quality evidence that use may improve depressive symptoms or risk of depression when used preventatively, but has no impact on disability after stroke. And then another
Cochrane review evaluating the effects of pharmacological and psychological continuation and maintenance treatments for persistent depressive disorder. So that was defined as an illness duration of greater than 2 years, found insufficient direct comparative evidence for antidepressant therapy. There were 2 guidelines that were updated since the last review. NICE guidelines for treatment of general anxiety disorder in adults. For anxiety, NICE guidelines do recommend SSRIs as an initial treatment option, and then if that is ineffective, an alternative SSRI or an SNRI can be used. For panic disorder, the recommendations were mostly unchanged from the prior update. Antidepressants are recommended if the disorder is long-standing or if the patient hasn't benefited from psychological interventions. And then if there's no benefit from initial treatment, a different antidepressant from a different class should be considered. The second guideline update was for depression in children and adolescents. NICE guidelines don't recommend pharmacotherapy except in combination with concurrent psychotherapy. Fluoxetine is what they recommend as an initial treatment option for children with moderate to severe depression that's unresponsive to psychotherapy. And they do make specific recommendations against the use of paroxetine, venlafaxine, or tricyclic antidepressants in children and adolescents. And then the new indication for esketamine is for patients with depression in adults and acute suicidal ideation or behavior, and that was based on 2 identical double-blind 4-week multi-center randomized controlled trials. Esketamine overall did not decrease acute suicidality compared to placebo based on low-quality evidence, but it did improve depression symptoms overall with a mean difference in the Montgomery-Asperger Depression Rating Scale of about 3.8 to 3.9 points compared to placebo at 24 hours. And overall, these scores were maintained at 28 days. So the MADRS rating scale, the clinically important difference that's referenced in the literature is about 2 points on this scale, and so these changes could be considered clinically significant. There were several study limitations that are relevant for these studies. There were broad exclusion criteria which limit applicability for patients with any comorbid conditions, and depression is often co-occurring with other conditions. There's also limited applicability to outpatient setting. The majority of these trials were conducted during an inpatient hospitalization. Patients in these trials were required to be hospitalized. And one of the trials referenced the average inpatient hospitalization stay of around 21 days, and these trials were only 28 days in length. Overall, the suicide rate, suicide attempts was low compared to current epidemiological data in these trials, and authors attribute that to the pretty rigorous standard of care that was used. Patients had to be admitted to the hospital and get wraparound services. Less than 5% of patients received psychotherapy during this 4-week treatment phase, which is probably representative of the fact that most patients were admitted to the hospital during the majority of their treatment. And then there's insufficient evidence for other outcomes, including suicide attempts, hospitalizations, or hospital length of stay in patients with major depressive disorder and risk for suicide. We did discuss this with the Mental Health Clinical Advisory Group, this indication specifically, and I wanted to share with you some of their thoughts on this indication and on esketamine in general. The conversation mostly surrounded the fact that esketamine should be an option for patients who truly have treatment-resistant depression, and particularly for those with treatment-resistant depression and suicidality. But they didn't think it was necessarily an appropriate option for patients who didn't have trial or failure of other standard therapies. If patients haven't had the trial and failure with other standard therapies but are acutely suicidal, their recommendation would be to follow current standard care with hospitalization for those patients if they are acutely suicidal. So their recommendation was that esketamine in those that are acutely suicidal would probably be more of an inpatient drug rather than an outpatient drug. At prior meetings when discussing esketamine, the Mental Health Clinical Advisory Group did note that diagnosis for treatment-resistant depression is difficult, and there are often overlapping symptoms with other conditions. And so getting to a diagnosis of an accurate diagnosis of treatment-resistant depression is problematic. They also raised concerns about the limited data for esketamine research, particularly with longer-term outcomes and the lack of standard for treatment after the induction phase. So the recommendations that we're presenting today are to make no changes to the PDL based on the current clinical evidence, but to update the PA criteria to accommodate this new esketamine therapy. And so the PA criteria allow for continuation of therapy if esketamine is initiated during a hospitalization. And then the third recommendation is we're going to look at these costs in executive session. So just to show you the updates to the PA criteria, the full PA criteria is in your packet, but the updates that we're making are to question number 4. So asking if the request is for maintenance dosing of esketamine or if the request is for continuation of esketamine after initiation during a recent hospitalization, and then they can go to the renewal criteria. And then in the renewal criteria, that starts at question 10, and we're adding a question to accommodate getting up to completing the induction phase if they've started it in the hospital. And then this isn't in your packet, but I thought it would be worth adding is question number 11 to ask if the patient has continued to maintain adherence to an oral antidepressant therapy, because esketamine is only recommended as an adjunct to other antidepressants. So I'd be happy to take any questions if people have them.
Yeah, esketamine, the data for this drug is so interesting. The trials that they use for approval, 21 days is about 10 days longer than your average inpatient stay for major depression. So, so the treatment, the data that they used, the applicability to an outpatient population, I don't know. I have so many questions about the data that was used to get esketamine approved at all. But I think definitely we need to, with the PA, we don't have any questions about the PA criteria. I think I'm okay with them in general, but this is definitely a medication that bears a lot more scrutiny than your average antidepressant.
Thanks, Rod. Any other questions for Sarah?
This is Tim. Is there any recommendation for requiring behavioral health therapy, counseling and that type of service as part of the therapy?
Well, so you have to be REMS certified to provide the drug. But as far as, and I guess I should have jumped in here, Sarah may actually know this better than I do, but I'm not aware of any requirement in the REMS that the patient be enrolled in psychotherapy or behavioral therapy.
I actually wonder about the continuation of this treatment, even if there is continuation of the severe depression and not resolution of the symptoms. And this is based on a direct personal experience, not with me, but with one of my patients. Where there were severe things. There was hospitalization. And there was actually have the wrong diagnosis here. We should be actually focused on this other thing. And I'm not sure how we address that within the PA criteria, but it seems like if someone has a hospitalization and they get discharged and they're using esketamine after the induction phase or whatever, but then they have another hospitalization, that's kind of a reason to say we probably don't need to continue this.
Well, I think that item 10 does address that, in that you have to document there's demonstrated adequate response during the induction phase. So, I mean, I guess that part.
6 or 8 weeks after.
True. And then in terms of treatment, yeah, I mean, I think rehospitalization, that's a tough one, especially when 40% of people with a psychiatric diagnosis have a second psychiatric diagnosis. So I think it might be difficult to necessarily separate. Even if the esketamine was treating depression, they could have PTSD or an anxiety disorder that could lead to a hospitalization. So I don't know that you could necessarily separate those out in any kind of feasible way.
We can do a policy evaluation so that we look at a future meeting people that have been authorized and durations of therapy and see if that might warrant us considering adding some additional questions about some kind of outcomes for renewal.
I think that'd be great.
Okay. So hard to kind of really add that now. You're okay with the recommendations that Sarah's put in front of you?
Yeah, I think it's very difficult. It's just what Russ was saying. It's like this is an interesting drug. It seems to help some people, but it's also an interesting way that it was sort of approached, because it's not really connected to the reality of the world that we work in. But yeah, more study on how this is working and how people are using it and whether or not it's actually having an impact that's a positive impact is I think important. Particularly, I think we have to recognize too this drug has a significant risk for potential for diversion.
You bet. Theoretically.
Well, Michael Jackson liked it.
Well, there are other questions for Sarah. We do have public comment from the manufacturer's representative. Stephanie Yamamoto, are you able to unmute your line?
I'm here. Can you hear me?
Can hear you fine. The floor is yours.
Great. Thank you so much. Yes, my name is Stephanie Yamamoto. I'm a pharmacist with Janssen Scientific Affairs. And I think I'll use my time to address the conversation that was had after the review. Thank you so much for teeing up those issues that talked about with regards to the site of care restriction. And I just wanted to point out that in the Spravato clinical program, the protocol requirement for initial hospitalization was appropriate and ethical in approaching investigating this experimental treatment for patients that were experiencing suicidal ideation or behavior with a major depressive disorder. And with regards to that also, these studies were the first registrational programs to evaluate antidepressant efficacy as part of clinical trials. And because of the at-risk population, that is why such rigorous standards around inpatient psychiatric hospitalization was used, primarily as the safety measure, as I had indicated previously. The standard of care that I also wanted to note also included twice weekly inpatient visits, outpatient visits post-discharge from the hospital, and also substantial clinical contact for multiple hours at a time with a dedicated healthcare professional. And while this is what is defined as standard of care within the randomized controlled trials of Aspire, I would submit to you that this may not be the standard of care in the real-world setting, as you pointed out. Another item to note is that there are only 2 inpatient facilities available in the Pacific Northwest, in Twin Falls and Longview, Washington. And to my knowledge, none are in Oregon. So I think those are things to consider with regards to the site of care considerations. One other aspect is the APA, the American Psychiatric Association, MDD guidelines. They do recommend that the psychiatrist should determine the least restrictive setting for treatment that will be the most likely not only to address the patient's safety, but also to promote improvement in the patient's condition. And so we acknowledge that the decision to hospitalize the patient is a pretty complex one. And the recommendation from the APA is that the decision is best decided between the healthcare provider as well as the patient. The ASPIRE studies did meet their primary endpoint with evidence of a statistically as well as clinically meaningful reduction in depressive symptoms as measured by the MADRS scores at 24 hours. Rapid reduction of depressive symptoms may serve as an important approach in this highly vulnerable population until additional comprehensive therapeutic measures may be set in place. And with the focus that the Oregon Health Authority has on this at-risk patient population, we would respectfully ask for Spravato's prior authorization to be considered with regard to the site of care access. Thank you.
Thank you, Stephanie. Any questions for Stephanie? Okay, thank you. All right, Sarah, back to you.
Yeah, so the recommendations that are in front of the committee at the moment are to make no changes to the PDL, but to update the PA criteria to allow continuation of esketamine therapy if it's initiated during a hospitalization.
We need a motion for the PA criteria update.
Seconded.
All in favor? Aye.
Aye.
Aye. Any opposed? Okay, motion passes, and we'll come back after exec session to discuss potential PDL changes. Okay, with that, we'll move on to our final topic before we go to exec session. We have the NSAID class update, page 174 in your packet, and we'll turn it over to Kathy Centena.
Thanks, Roger. Yeah, today we'll just be talking about new information that's been identified since the last review, which we did in March of 2016. Our current policy for NSAIDs is that we have quite a few preferred agents on the PDL. Non-preferred products do have to go through the PA criteria, as well as for ketorolac use beyond 5 days, just as recommended in the labeling. So through this review, identified 8 different systematic reviews and meta-analyses that we'll touch on briefly. The first one was done by AHRQ for the treatment of chronic pain. This did include traditional NSAIDs as well as selective COX-2s. And overall, the evidence that was most robust was for patients with OA and RA, and it did find that NSAIDs reduced pain as well as improved function with a number needed to treat of 10. There was insufficient evidence to differentiate between the different responses of the NSAID products. And for other indications such as headache and back pain, again, the evidence was insufficient to really draw strong conclusions. They did note some safety impacts of NSAIDs as well. Diclofenac was associated with a small dose-dependent increased risk of cardiovascular outcomes events, as well as diclofenac and celecoxib were associated with moderate risk of coronary events. Ibuprofen also had this risk at a larger risk as well. And then lastly, not surprisingly, GI events were also increased compared to placebo with diclofenac, ibuprofen, and naproxen. Looking at the next systematic review, these 2 were done with celecoxib. The first one in patients with osteoarthritis. The main outcome that they looked at was a relative improvement in pain compared to placebo. And what they found there that celecoxib did improve pain more than placebo with a number needed to benefit of 12. Celecoxib also improved physical function with a number needed to benefit of 14. Looking at celecoxib use in rheumatoid arthritis, similar results were also found with clinical improvements in pain as measured by the ACR-20 that benefited celecoxib patients with a number needed of 7, as well as a reduction in pain with a number needed to benefit of 4. Noted 2 were fewer gastrointestinal ulcers in patients treated with celecoxib compared to placebo, but also compared to traditional nonsteroidals.
review. We have lots of good Cochrane reviews for this one. It analyzed the use of NSAIDs in the treatment of chronic low back pain. Again, pain reduction was measured, and NSAIDs were found to be slightly more effective than placebo with a decrease of 5 on the 0 to 100 VAS scale, commonly used to measure pain. This did not meet the threshold for a clinically important difference of 13. So again, those differences were small and may not be clinically meaningful. Again, similar results were found with patients treated for acute low back pain in that NSAIDs were more effective than placebo. Again, a decrease of 7.29, so not quite meeting that threshold. Although these patients did, about 7% more patients treated with NSAIDs did note pain relief and 8% improvement in disability. So there was some benefit to NSAID therapy. The last one looked at Cochrane review of acute soft tissue injuries, and pain relief there was studied, and they didn't find any really meaningful differences between the use of NSAIDs and acetaminophen or NSAID and opioids for pain relief. And again, I should mention for that one, it was mostly traditional NSAIDs that were studied. Moving on, we have a couple systematic reviews here that weren't related to pain. The first one in infantile seizures, the use of intermittent ibuprofen was studied compared to placebo on reducing the risk of recurrent seizures at 6 and 12 months, and no difference was found between the two groups. And similar findings for intermittent rectal diclofenac, in which there was no reduction seen compared to placebo. The next review was a Cochrane one done with oral NSAID therapies in patients with cystic fibrosis. They looked at 3 main outcomes here. Percent predicted FEV1 and percent predicted forced vital capacity were both improved slightly with NSAID use, around 1%, compared to a decline with placebo around 2 to 3%. Hospitalizations, though, were decreased with nonsteroidal use, in which the NSAID incidence was 268 per 1,000 patients treated versus 440 per 1,000 patients treated with placebo. Moving on to guidelines, we had 3 guidelines here for low back pain. They all were on the same page in that they strongly recommended the use of nonsteroidals, either first line or again with a strong recommendation for low back pain. And this was through the American College of Physicians, the Veterans Fair, and then the National Institute for Health and Care Excellence. For chronic pain, we had 1 guideline from the American Society of Clinical Oncology that said that NSAIDs were strongly recommended for those cancer survivors with chronic pain. Or sorry, I guess it was a moderate recommendation, not a strong recommendation. And then moving on, we have a couple randomized clinical trials that were identified. The first one was a double-blind non-inferiority trial in patients with OA and RA who were using nonsteroidals and were at increased cardiovascular risk. So this trial was looking at cardiovascular outcomes of naproxen compared to celecoxib as well as ibuprofen. The composite primary outcome was cardiovascular death, non-fatal MI, or non-fatal stroke, and all results were that they found non-inferiority. So celecoxib was non-inferior to naproxen as well as non-inferior to ibuprofen, and ibuprofen was non-inferior to naproxen. That was about a 20-month study. The second one was a double-blind randomized control trial that looked at, again, patients with OA or RA that were at increased GI risk to look at gastrointestinal outcomes. And this trial compared celecoxib to combination therapy with diclofenac and omeprazole, and found that the incidence of GI events were lower with celecoxib with 0.9% compared to 3.8% with the combination therapy. And this was a 6-month trial. We're moving on to some safety warnings. Just 3 quick warnings to go over here. For the ketorolac nasal spray, there was a recommendation for label change that it should not be used in pediatric patients less than 2 years of age. With celecoxib in general, as we just discussed, they updated the labeling to state that it was non-inferior to naproxen and ibuprofen for the risk of cardiovascular, thrombotic risk, as well as non-fatal MI and non-fatal stroke. For that whole composite outcome of cardiovascular death, non-fatal MI, non-fatal stroke. And then lastly, there was a general non-steroidal class warning
describing that there was an increased risk of kidney problems in unborn babies that resulted as because of low amniotic fluid in mothers that use non-steroidals. So the recommendation for this class is based on the evidence. There's no changes to the preferred drug list, that we should evaluate cost in executive session. I was going to go over the PA criteria just briefly. Starts on page 197 in your packet, and there's no real changes. Just you can see the items in red there. We just added the nasal spray to the ketorolac recommendation on this slide, and then on the next slide, again, just did some clerical clarifications in red, but no real changes to speak of.
Great, thank you, Kathy. Any questions for Kathy? Okay. Again, recap your recommendations.
Sure. So, based on the evidence, there's no new evidence for the class to recommend any PDL changes, and that we just review costs in executive session.
Fantastic. Okay, we are about to go into executive session. We are endeavoring to have a new functionality with our Zoom, so we're going to have a breakout room. I need to find Sarah here and make her. Yes.
Do we need to have a recommendation
Well, thank you.
Yeah.
Yep, we do need a motion to approve.
So moved.
Second. All in favor? Aye. Aye. Perfect. Any opposed? Super. Hearing none, we are going to go into executive session. I need to read a short blurb. For the committee, we're going to open up the breakout room, and you will be able to go join that session. We'll make sure everybody's there before we start to get into confidential pricing. We will not make any decisions or recommendations in exec session. We'll come out into open session when that concludes to make all recommendations for the PDL and any classes that we deferred action taking on with PA criteria. So with that, I need to read a blurb. The P&T committee will now meet in executive session for the purpose of the consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to ORS 1926602F and ORS 4143551 and 2, which allows the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that is necessary for the committee to make final recommendations or to comply with the requirements House Bill 2100. Representatives of the news media and designated staff are allowed to attend the executive session. All other members of the audience will be left out in the general Zoom room. Representatives of the news media are specifically directed not to report on any deliberations during the executive session except to state the general subject of the session as previously announced. No decisions may be made in executive session. At the end of the session, we'll return to open session and welcome the audience back into the room. Okay, we are back from executive session. Let me just make sure. Please co-host. Super. We have a few things to go over, so thanks for everybody's patience. Looks like a few people have been waiting for us to return. So we have some things to discuss and also some recommendations from executive session. So I'm going to go through these classes one at a time, but the first thing I wanted to lead off with, there was a question earlier in the meeting. We said we talk about an executive session. What kind of thresholds do we have when we're looking for savings? And so for the public, I just wanted you to know, generally we're looking to try to find about $10,000 per quarter in savings. We think that's juice worth the squeeze. And individually, sometimes in classes that have less utilization, we try to shoot for like $1,000 per member per year. So if we can save $1,000 on getting a patient to switch to a different medication, that seems worthwhile and compelling for providers to consider those changes when we bring them to their attention. So I just wanted to make that publicly known. So we did review several classes that were mentioned in open session. So the anticoagulant literature scan was one of the first classes. After review in executive session, the recommendation was to make delta-parent syringes non-preferred on the PDL. So I'm going to take these classes one at a time. Is there any discussion, or do we have a motion to approve?
So moved.
Second. All in favor? Aye. Aye. Fantastic. Next class we reviewed in executive session was the Duchenne muscular dystrophy class. The recommendation after reviewing confidential pricing was to make no changes to the PDL. Do we have a motion to approve?
Motion. I'd like to add just a comment on the medications, particularly exon skipping medicines. We still are lacking data on any sort of long-term impact on things like pulmonary function and meaningful measures of disease progression. So, I'm hopeful that we'll see some information on that will help to guide whether or not these medications, which are incredibly expensive, are really providing some longer-term benefits for patients and families who are receiving.
Appreciate that. Any additional conversation? That's something certainly my team can take away to try to look for any evidence that comes out in that or any studies that support or provide that, shine a light on that.
I'll just say, I think back in July when we last reviewed that class, I know we really struggled with renewal criteria in determining efficacy, and I think the way that you ended up wording sort of a vague but some attempt to demonstrate some clinical benefit, I think that wording worked out well, and I'm sure we'll probably need some more wording for soon-to-come approvals.
Appreciate that, Pat. Okay, so again, the recommendation is, and we heard a motion to make no changes to PDL. Second, all in favor?
Aye.
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 Any opposed? Great. Next class was the acne class update. After reviewing executive session, the recommendation is to make benzoyl peroxide lotion and erythromycin benzoyl peroxide gel. The benzomin is generics preferred. And to make benzoyl peroxide towelettes non-preferred on the PMPDP.
Motion to approve.
Second.
All in favor?
Aye.
Aye.
Aye. Aye. Any opposed? Okay. For the smoking cessation literature scan, we deferred taking any action on the proposed PA criteria. Let me first take, after looking at pricing of agents, confidential pricing exec session, the recommendation is to make no changes to the PDL. So let's take care of that recommendation first. Motion to approve? Second? All in favor?
Aye.
Aye. Aye. Any opposed? And then the other question was to the committee to recommend updating the PA criteria to allow therapy for 2 12-week treatments for varenicline for patients 17 and older. So I wanted to open it up to see if there is some question from the committee. I think yeah.
Yeah, I think that based on the public health need and the benefits of quitting smoking, I think that we should encourage the use of evidence-based treatments. And so, certainly, at least those items that are preferred agents, I think we should enable, whether through auto PA or not requiring a PA. I think we should allow them to get refills as often as they're needed. So I think we should. My initial thought is to change the renewal criteria to only require PA for non-preferred agents.
So I'm hearing to update the PA criteria as proposed and amend to only apply to non-preferred agents. Or only, yes.
And I think that, Roger, we'd also like your staff to be able to look at the basically count of patients who are started on different approaches and then their numbers of refills that they have within, a 6-month time period or within a year or whatever, to go back and look retrospectively to see if a patient starts on a medication, how long do they continue it as a general rule? Because that would be useful to inform the prescribing community about which ones are the ones that are most likely to have continuation or discontinuation of treatment.
Perfect. We can take that away as a policy evaluation to see what's happening when we change the criteria, as well as try to look for some persistence with members that are getting the agent. Okay.
Aaron, I was actually interested for the committee to review whether or not there's actually any additional long-term evidence, like for use of the Chantix beyond the 6 months as well. I'm not familiar with there being new guidance on that, so I just want to ensure that we're encouraging an evidence-based strategy.
And I'm trusting my team is taking notes on this as well.
One of my concerns with which in psychiatry I will call so-called evidence-based guidelines is so much of the research done in smoking cessation specifically excludes my people. So one of my significant concerns is trying to help my patients with bipolar disorder and schizophrenia to quit smoking, and they are excluded from virtually all research. And so, even if we have guidelines that are based on evidence, I think we would be excluding those people who statistically have a much harder time quitting, but who are also disproportionately affected by smoking.
I appreciate that comment.
Sounds like a great research study for someone who's interested in pharmaceutical outcomes. And there's data sets that are available. I mean, OHA and the CCOs and so forth includes that patient population, and it's possible to sort of assess those kinds of questions over the longer term. I'm with Russ. I think that it's hard to sort of make real well-informed decisions when so many patients are excluded.
You bet. Sorry, at the end of the day, I'm not sure if I took a vote. So for the PA criteria, was there a motion to approve the PA criteria as proposed and amended? Moved and seconded. All in favor?
Aye.
Aye. Any opposed? Great conversation. Thank you. For the end of the Preston class update, after reviewing executive session, the recommendation is to make the duloxetine DR capsule bupropion hydrochloride XL 24-hour tablet, which is Wellbutrin XL and associated generic, and desvenlafaxine succinate ER 24-hour tablets preferred. Make amoxapine tablets voluntary non-preferred, and also explore residual opportunities for dose consolidation for rhodioxetine and change forms to switch utilization from desvenlafaxine 24-hour tablet to the 24-hour tablet, or the succinate 24-hour tablet. So motion to approve. Second? Second. All in favor? Aye. Aye. Any opposed? All right, and finally for the end-stage class update, the recommendation is to make Telocicib brand and generic preferred, and to make Humez ODT, Florboprofen, and Ketorolac tablets non-preferred.
And to approve.
Thanks, Kathy. All in favor? Aye. 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 Any opposed? Fantastic. Well, with that, we thank you for staying an extra 16 minutes for the P&T meeting. That concludes our business for today. Stace and Bill, thank you for signing up for the heavy lift with me. And just as a reminder, the next P&T meeting is scheduled for April 1st.
Oh, April Fool's Day.
Oh, that's right. Yeah. That's right.